methodology for doing a OAGB, and then Andres will follow it with a standard for SADI-S. Thank you.
Yeah, thank you again. Okay, I will try. I have 10 minutes, yeah, or less?
10.
Okay, thank you again. I will try to, the surgeon, we have more and more today technique and some modification. I will show you our modification. This is my disclosure. This is my case mixed disclosure. And again, you know that sleep worldwide is the first place, but in Israel, the OAGB is about 73%. It's so far. Okay, the technique is the same. It must be, pouch must be tight, long, and I use only 5 trocars. This hybrid technique, the biliopancreatic limb, it must be between 150 meters, that's all. And I fix the afferent and the efferent loop. This is the position. I stand between the legs. It's for me very, for all the upper GI procedures, I prefer between the legs. This is the trocars. I use my left hand here and right hand here. This is the assistant, camera, the assistant, and the other assistant. This is what I do. This is the first step, okay? I use, the first step is, you see that horizontally, it's about 4.5 centimeters, and after that I go up. You see that pouch, it's very long and tight, okay? This is 2 points that we need to know. This is the two triangles here, okay, in the G junction. This is the dangerous area. Don't go there because you don't need to go there. You need to, this is our triangle. Okay, you don't need nothing. You can dissect this area, but don't go here. And it is we see again the same area posteriorly. Don't go here because again you can have bleeding and you can leave a remnant fundus. You see here, this is the crust, left crust. This is my area. I go here. This is the triangle that I use. That's all. It's a little open here. You don't need to soothe something only by dissected, and you can have it. And after that, you can finish the procedure, the pouch. This is the first step. After that, all we need to do the trites. I take 1.5 to 2 meters, and the anastomosis, I perform retrogastric, and I use end to side. Okay, I said because if I use end to side, the pouch is long. And when I use side to side, my pouch will be less 5 centimeters. Okay, I don't close the defect before the anesthetist push the gastrolavage tube 34, 36, and you see that the gastrolavage tube is in the efferent loop, and I can close the defect all the time. Okay, this is the test, and I fixed the efferent and the afferent loop. I will show you. This is the video. It's 7 minutes. Okay, what I see that first of all you need to go to the to the angles here. This is very difficult for some surgeons, but in the left hand I take I take the lesser momentum up. And I perform a little windows here. Okay, this is the use. And after that, the first assistant from the right side, he start and he can go. You see, I don't say that, I use only in the upper part, only white cartridges. No bleeding, no leaks, my friends. I use it more than 10 years, okay? I don't use blue or I don't know. Now, I put again the echelon. You see that I go vertically. Before that, I ask the anesthetist to push the gastric lavage tube. I use only 33 or 36 not more. And you see that the pouches will be very tight and very long. And I think 12 years that I use the white cartridge in the upper part of the stomach, really you see no oozing, nothing. And this is what I talked to you, that I open the GE junction, okay? I don't go to, this is my triangle, I don't go to the spleen. And I feel here the crust, it must be, I open, little open. Sometimes I can, when you did this, you can see here sometimes, all the time, when I do that, when I see hiatal hernia, I repair it. I don't leave it, okay? We talk about that today, that patient with hiatal hernia, they can suffer from reflux. Okay, now I go posteriorly again, the same triangle, okay, that I said to you that you don't go to the right side, you need to go to you need to find the left cross, and you can open there, you don't need nothing, you see that the cross, and you can see everything, and the spleen here, and it's enough for me. Now I can, this is my pouch. I use sometimes vertically 4, sometimes 4, all the time 4, sometimes 5, but you know that it's 5 centimeters or 6 centimeters, it's not the same because when you use it, it will be about 4 or 5 centimeters. Now you see, this is my pouch, and I perform a little gastrotomy in the right, posteriorly in the right side. Okay, I don't use I use it retrocally, but in the right side I don't use here, because if you have some anastomosis from left side up, my pouches will be shorter. I don't want my pouch to be shorter. Now we go to the trites. I measure from the trites about 1.5 to 2 meters, okay? I use 5 centimeters by 5 centimeters. I don't use 10 centimeters, and step by step in the same side, okay? I don't measure all the small bowel. I measure it only with the patient are very, very BMI more than 50 or revisional surgery. I measure all the small bowel. When the patient is like this, primary, I measure 1.5 to 2 meters. And this again, I perform a little enterotomy. It's enough, less than half centimeter, not more. That's all. And again, I use my white cartridge too. Okay. This is who performed this, the anesthesis, my assistant here. I give the assistant, my assistant to perform that. And you see, I perform on end to side. Okay, we take before you check that the gastric lavage tube, it's a little up, don't take the lavage tube. And I come from the right side of the patient, and I perform 3.5 centimeters, but when I close it, it will be about 3 centimeters. I think it's enough. Okay, now I ask the anesthetist, I don't close without, before the bougie, the zonda, gastric lavage tube are in the efferent loop. It's in now. Here you can close it. You can take another shot. It's totally, you can use it. You can use it manually from the right side to the left. I use here my left hand, okay? Why I use my left hand here? Because the stitches, when I use left hand, it's not stitches like Z stitches. And I use my right hand here, it will be Z stitches. Maybe they can have structure. I use only one stitch. Here it's Vlog 30 absorbable. I take it from the left side to the right side, ceremuscular all the way. Only one layer. I don't use 2 layers. Only one layer is enough, because if you use another layers, maybe they can have some strictures. Only one layer from one side to the other side, and you see this. You don't see the staple line from the pouch. Okay. After that, I fixed the efferent loop with the remnant stomach, because sometimes the efferent loop is a little twisted. What I do, I put the stitch from here, I put omentum in between, you will see. Okay, this is also all the time my left hand. Okay, I fixed the efferent loop. Before I fix it, I asked the anesthetist to remove a little the tube. And you see, I fixed the efferent loop now in the same stitch. And you see that the efferent loop, it's not twisted, okay? Also, I fixed the afferent loop. For me, it's not anti-reflux. Some surgeons, they said anti-reflux. I don't believe that because we don't have RCTs on that. Before I do it, this is the leg test. You see that the diameter of my small bowel is like the same of the pouch. Why I fixed the efferent, you see here some stitches. You see that? This is, for me, this is the tension area. This is very tension here. What I do, I take it a little, the afferent loop up, because now it's tension-free, like that, okay? I don't believe in it. This is the first, why I do that. The second, when you have the food you can't go back, because I have a little, the afferent loop a little up, and the food will be one way, from the pouch to the efferent loop, not back to the afferent loop. Some surgeons, they think this is anti-reflux. Okay, maybe, I don't know, but this is the technique. I don't leave no drainage. You see, this is after the procedure, no bleeding, nothing. I put the omentum in between here, and this is the procedure. It's about 40 minutes, that's all. Okay, when you when I started to standardize the technique, really, I don't see bleeding. I don't see, of course, not zero, okay? I don't see leaks. I don't see, it is very easy. But for me, this is best way, because this is very reversible and revisable technique that we don't have in Roux-en-Y or in another procedure. It's less surgery than a PPD or SADI. Okay, it's high percentage of success and low operative time, and this is very faster and simpler technique, I think. Thank you very much. Okay.
Este no es. Okay, I think I have presented today some of the steps of the procedures I do it, so you will recognize them. Let me see. I stand also in between the legs of the patient, head up as much as possible. 12 centimeters from the xiphoid process, I introduce the optic trocar. This subxiphoidal trocar is for my left hand in the moment of dissecting the mediastinum, and then is the liver retractor. And as you see here, this is my right hand for almost the whole surgery. This is left hand or liver retractor, and this is left hand or liver retractor. No? So the first part I use 4 trocars, and then the 5th trocar is, I think the substitute of the 5th trocar is the position of the patient and the omentum pulling from the stomach down. So I can access to the left cross of the diaphragm perfectly well without the need of an assistant retracting or pulling from the omentum. So this is the first step of my operation. I go up as much as possible to that area that you didn't want to go, Nasser, to divide all the short gastrics from this splenic area, and totally dissect the fundus of the stomach from the diaphragm. This does not pretend to be to construct a very narrow tube, to be very close to the esophagus, just to mobilize the fundus and to be able to do a correct slave gastrectomy. Divide all the adhesions. It's the same initial part of the surgery that you do with a Nissen procedure or any anti-reflux procedure. Completely dissect the left cross of the diaphragm. Here, as I told you, my left hand is in the upper trocar. And then I change my left hand to the lower trocar, and my assistant retracts the liver. I go to the medial part of the greater curve of the stomach and continue dividing all the branches of the gastroepiploic arcade. First up, to find my first steps of the dissection. Find that the fundus is completely mobilized, and then go down to prepare to the duodenal dissection. It is true that in the primary SADIs, I do this part of the operation in between the legs, but if I am doing a revisional surgery as lift to SADI, I stand at the left-hand side of the patient for the whole surgery. So dissection is well done from the left-hand side also. You saw that the assistant is now retracting the stomach. So assistant goes from the stomach to the liver, from the liver to the stomach, depending on where I'm dissecting. And it's important to divide all adhesions to the pancreatic surface and to complete, as you saw this morning, the dissection of the greater curvature first. So these are the steps that you have seen here. And the aim is to obtain this vision in which you are raising the duodenum with your left hand in right angles with the pancreatic surface. And we suppose that the GD artery lies in this diateric angle. Here you see the artery. You can dye it or not dye it. The artery is not going to be seen with ICG, but small vessels are going to see. And if you open this window, you can easily see the liver or even the bile duct down there somewhere. Then, as I told you this morning, I complete the greater curve of the duodenum. Here you see the bile duct. It's not so green. And this is in the video. So it's the same patient always. So the surgeon is holding tight the duodenum upwards in right angles. I use these graspers with a long blade because I think this will not damage the serosa of the duodenum. And it's true that some people tell me that I go too close to the pancreas or the duodenum, but these are not real thermal injuries. All adhesions are divided, small vessels from the GD artery to the duodenal wall, to the posterior duodenal wall. Even sometimes you have to detach some parts of the pancreatic head from the duodenum to gain some millimeters that will be good for the later anastomosis. And in the first years of my experience in SADIs, I used to put a vessel loop around the duodenum to hold it because I was in fear of damaging the serosa, but it never happens or rarely happens. I'm going to speed it up a bit. Then the assistant retracts the liver and we go to the hepatoduodenal ligament. First, complete this area. And then open just the peritoneum. You see the bile duct. The peritoneum overlying the hepatoduodenal ligament, just to dissect the duodenum downwards, as when you are initiating the Cover maneuver. Although in this surgery you are to the left-hand side of the bile duct instead of to the right. But I find it good to completely dissect the duodenum from the gallbladder, although perhaps you can think that you don't need this for completing the anastomosis, which is going to be proximal to this area, but I think it helps. So once you have done it, you can pass easily the duodenum from behind, always in the same ways. You see, I don't see the pointer here. Well, here you have to take care because the dissection has to go not too crossed with the duodenum because you can damage the anterior wall of the duodenum, not too up because you can damage the bile duct or the proper hepatic artery. And this hole has to be as large as possible to be able to easily introduce the stapler. With the, I prefer to put the anvil upwards and the cartridge downwards. So you complete this hole. And later on, when we do the sleeve, I'm going to speed it up, I come back again and try to complete this dissection if I find I can do it. This is quite safe. We have gone 1 or 2 centimeters further than the gastroduodenal artery. So the window is enough to complete the surgery. We are going to leave a wide sleeve, at least 5 to 6 centimeters, because the antrum is going to be big enough to have motility preserved. I use always black cartridge for the sleeve gastrectomy from the antrum to the top of the stomach. Why? I don't know. Once my boss came to the OR and said, from now on, all our sleeves will be with black cartridge. And so I do it. And I think there's not a great difference. Yeah? No. I'm superstitious, I cannot change. So this is the standard position of the tube, and as you see, reinforced black cartridge staplers for the whole sleeve gastrectomy. I think the most important is the first fire, because here you are warranting that the sleeve is not going to get twisted. Separate from the incisura at least 1 centimeter from the tube, and the rest is a normal sleeve gastrectomy, as you see. Remove completely the fundus. Sometimes when I have a small part of the stomach left, I use a purple cartridge, non-reinforced, but a few times, as you see. You consider this dangerous, no sir? Dangerous. So, after completion of the sleeve gastrectomy, we come to divide the duodenum. So, this is the same case, now a bit more bleeding. Still in between the legs, divide these adhesions to the posterior part of the, from the posterior part of the stomach to the pancreas. Demonstrate that there is no important vasculature there. Again, see the GD artery and complete dissection. It's always possible to do more dissection, so I like to do it that. And from the left-hand side trocar, the left subcostal trocar, introduce the stapler, the anvil to the right-hand side, to the hole you have made, and the cartridge to the lower part of the duodenum. Try to divide it as much in right angles as possible. Although I've seen people doing an oblique transection of the duodenum, and you have a wider segment to perform the anastomosis. And I told you also that this is, in this video, is purple cartridge. Now I use the vascular one, the tan one or the white, depending on the here is it. And you see, always, you can never say always, but it's almost impossible to have an injury to the bile duct. Then I leave a stitch here. This is very important because when you are changing the position of the patient, the duodenum is going to be buried behind the column and the omentum. And so this stitch will serve to find in behind that fat the duodenal cuff. Okay, so we move. I have a problem with the order of the videos. We move to the left-hand side of the patient, and I place, for measuring the small bowel, I place the scope here. In this video, I used to use a mark in the graspers, and go measuring from 5 to 5 or from 10 to 10, always relaxing the small bowel previously with Buscopan. Here you will see the hands-on anastomosis, and here you have the measuring of the bowel, and when we end here, I'm sorry, we will see the stapled anastomosis. The first stitch that we left in the duodenum is the stage suture for starting this anastomosis, and it's usually a barbed suture 3/0. And now, as I told you, the scope is in the middle, right hand in subcostal position, left hand in right paramedian position. Always open wide the two defects, the two holes, to facilitate the introduction of this stapler. And never try to calibrate with an NG tube or nasoduodenal tube, because I find it almost impossible to introduce it through the pylorus, although there are people that have reported it in the duodenal suites and in the SADIs. I always do double layer for all anastomosis. I think only the bile duct or the pancreas can be different. And I'm going to speed it up after firing. As I began the suture of the defect always for at the posterior part, to be absolutely sure that the corner is completely closed. And then a running suture covering the whole defect, but going all through the anastomosis to the right-hand side of the duodenum, and then I come with the stage suture to cover it again. So you can tell me that it's not a double layer, it's 4 layers really. But I feel safe, and even in these cases, you can, with this suture, you can have a 1% leak rate, perhaps less. We compared both anastomosis. I think the hands-on takes about 20 minutes and the other about 10 minutes. But my residents measured the videos and they were not significantly different. And in terms of safety, as I told you, they are both equal, they behave all equal. So I think that's all. And results are what I told you about 1% leaks and an eye leaf drawing here. Okay, thank you.
Thank you very much, Nasser and Andres, for the very detailed videos. Any questions for the tips and tricks how to do the OAGB or how to do the SADIAS? Yeah, go on.
Yeah, just a quick question. Do you reinforce the duodenum stump, and do you have any problems with it? No, never. Never had any problems? Never. I think duodenal stump leaks are more related to the tension in the area, and so are more frequent after gastric cancer surgery or peptic ulcer surgery, because the biliary limb is short and a twist in the anastomosis can give rise to a rise in the tension, in the pressure, but in SADIs it's a very long limb, and usually there are no high pressure there.
Hi, I was wondering when you do the stapled anastomosis on SADI, the SADI procedure, the staple line on the duodenal stump, you leave that as it is, because when you suture it into the anastomosis kind of, but when you staple it, the new staple line will be right next to the staple line of the duodenal stump. Aren't you afraid of?
No, because I have never seen a problem with that crossing of the staple lines. I think it's a bit a myth.
But you can have a small portion that is potentially without vascularization.
I don't see it, and I think, as I told, it's a myth from the past. We have demonstrated also with your anastomosis that you are crossing staple lines and that nothing happens. What do you think?
But you see that when I use the stitch or the staple line, I don't use the staple line because I use seromuscular. I use from the pouch to the small bowel. And the staple line is inside, it's inverted.
Yeah.
It's a simple technical question. When you do your anastomosis between the duodenum and the small bowel, I've had on some occasions that there's a kink at that, the left part of that anastomosis, and that it kind of can create a stenosis. And I've had one patient who had a leak because of that. So do you have a trick to avoid this kinking at the left part of the anastomosis? See what I'm saying?
It's like the anti-tension suture.
Yeah.
I've only done it once. It's true that sometimes when you do the water tightness tests, which serves to know how the duodenum is emptying into the small bowel more than to find any leak, you can feel worried about this, concerned about this kinking. Perhaps if it's clear, I will do it also. Yeah. Thank you. Just one question there.
How many times do you need for SADI surgery?
Sorry?
How many times do you need for SADI surgery? Is a standard situation.
The duration of the operation?
Yeah.
Well, the fastest are 45 minutes, and it's usually around 70 minutes, including liver biopsy, introducing chokers, 70 minutes or so. Dan Kotam said once that his standard studies is 35 minutes. I find it a bit fast.
I find 70 minutes fast as well.
Well,
No, that's fine.
he takes 45.
I think it's the volume, yes, I think it's the volume. And I think that's what it shows. The more volume you do, you get slicker and smoother and better. And the whole team, I think nurse, assistant works like a Formula One pit team. And I think that's the key there. Okay, I think we'll finish that talk and we move on to next talk. Professor Jack Himpens will, thank you again, Nasser and Andres. Professor Jack Himpens will be talking to us about robotic one-loop surgery.
See how elegant? Okay. Thank you for having me here. I start by saying that there is no conflict of interest in my talk. And I'll show you a few slides that perhaps you haven't seen yet. Let me see. Okay, this is... Okay, this is March the 3rd, 1997. And this is actually the first robotic procedure done. I'm sitting there with totally useless glasses and supposedly to have a deep view. Here is the assistant, and you see the procedure was a cholecystectomy. And you see that the tools were not that fancy at the time, and this is a handmade, I would say, hook that was used for the dissection. And so the surgeon was sitting at the console, which was very simple at that time. Didn't look that fancy, but with the vision that we had, we could very comfortably actually do the dissection and perform a laparoscopic cholecystectomy from a distance. That was the first one. And we did two more that day. That was again in 1997. And you see there was a whole team that had come over from the US, from the team of Fred Moll. And, but you see that the principle is exactly the same as the intuitive system right now. You see the moving arm. We didn't have 4 arms or anything at that time. We just had 2 arms to perform the surgery, and one trocar was actually activated by the assistant who was holding the camera. But you see, this was a procedure that took a little bit over 1 hour, and I must say that that was probably the most nerve-wracking thing I've ever done in my life. Anyway, so the history, this was again March 1997. The procedure was a robotic cholecystectomy, and the year after that, in 1998, Guy Bernard Cadier and myself, we performed another procedure, which was a adjustable gastric band. That was the first, supposedly the first procedure, bariatric procedure from a distance. But again, the surgeon sitting at the console was like 10 feet away from the operative table. After that, the procedures really took off, and we see that other procedures were performed. Especially the urologists were interested because there was suturing, and theoretically the robot would help that suturing. So prostatectomies were performed, and from there we see that there was a number of indications that were adapted more and more. Now, why should we use a robot for a single anastomosis procedure, which is supposedly, by definition, a rather simple procedure? And still, thanks to the robot, to the improved vision, there is help from the robot. The foregut dissection is easier. The duodenal, if we want to do a SADI S, the duodenal dissection and the anastomosis afterwards are easier and are probably more precise. And I admired Andre's technique. And what I like in his technique especially is the logic of every motion. And I think the robot has one pro, which means that it really allows to repeat exactly the same thing of the same technique every time over and over again. So we get a consistent reconstruction. The reproducibility is therefore clearly improved and standardized. Now, what is the background? Now, the logic to perform a robotic procedure, single anastomotic procedure, is, I must say, that it's a new tool. It has proven its safety and efficacy in gallbladders. And then we have to be careful that the hospital buys the robot and tells you, okay, now you have a new hammer, so you need to see everything as a nail and hit on it. It must be said that the procedure is sexy, what I mean by that is that there is very few people in the OR, so therefore it's a quiet procedure, and this is, I think, kind of attractive. This is the outcomes. This is one paper. This is a meta-analysis that was published a year ago, or a bit over a year ago. And there you see what the outcomes are. There is a low rate of intraoperative complications, no mortality. The operative times are shorter usually than without a robot. The median hospital stay ranged from 2 to 6 to 7 days with minimal readmission rates. Again, we're talking about the single anastomosis here. Postoperative complications occurred in a bit more than 6% of the patients, according to this paper. And there was a significant weight loss outcome with a mean excess weight loss up to more than 100%. And so the outcomes are comparable, actually, to the outcomes without a robot. Here, this is a bit of a complicated scheme that shows you the risk of bias, because here you see the 7 papers that were published on the issue, and with each time the risk of bias. We have to be careful when we have a new tool, you know, the new hammer. We have to make sure that we don't try to err by hoping too much. Additional limitations of the evidence are still present, so we can't really generalize the principles of the single anastomosis by robot. The sample sizes in literature are still small. The designs of the procedures of the papers is usually retrospective. Usually they concern just one single center. There are different techniques depending on the center, despite the fact that the techniques are usually repeatedly the same center by center. They're limited long-term follow-up, so we still have to be careful with our conclusions. The cost remains a major issue, and the superiority of laparoscopy over laparoscopy without a robot has not yet clearly and at 100% been proven or demonstrated. Take home message: robotic single anastomosis bariatric surgery appears safe as far as we can tell by the small number of publications. It is reproducible, at least in the short term. There is a particular promise, we would think, in the use in complex procedures and in revisional cases. But current evidence doesn't yet establish clear superiority in long-term clinical outcomes. So the question is no longer whether robotic single anastomosis bariatric surgery is feasible. I think there's proof of that. But is it better? That I cannot swear on it. In what patients we can obtain added technical value is not still clear, and some new benefits are discovered, I would say, every day, depending on the type of procedure, and now I would say depending also on the type of robots. I think that was it. Thank you.
Thank you very much, Jacques, for your historical video that we had the chance to see. That's wonderful. And of course, thank you for your compliments. I have, any question from the audience? I have a concern about the introduction of robotic surgery. It seems that the robot that does it all, and we are seeing in the literature numbers that are somewhat worrisome. I remember a paper revealing that in the state of New York, the rate of complications after robotic cholecystectomy was 3 times the rate of complication after laparoscopic cholecystectomy. Somewhere I read also in Annals of Surgery that the mean leak rate after robotic esophagectomy was 33%. And recently there was some paper published in the States about the results of robotic one-way gastric bypass, doubling the complication rate of laparoscopic one-way gastric bypass. That's concerning, isn't it?
That's also why I tried to explain that it's the outcomes differ center by center. There are papers also that say that, for instance, for inguinal hernias or parietal surgery, that the number of complications is highly reduced compared to the regular laparoscopic procedures. So I think that's what I'm trying to say. It's still too early to really get with final conclusions. And we still have to be careful and hope that we can find with new types of robots, new types of procedures, better outcomes still than what we've had so far. But what you say is true. And, again, this was in 1997. We had done at that day, before that day, we had done, I think it was 11 cases in animals that we had done. And there's no way that nowadays we would get the okay from the ethical committee. But, it's 20 years ago, and then we could still get that.
Yeah, thank you. Any questions?
Thank you very much.
Yeah. We have to start the dance again.
And our next speaker is Dr. Parmar, so he's going to present us a lecture on the day case bariatric surgery. Thank you, Chidan.
Thank you very much. First of all, thank you all for staying here whole day. Thank you, Andres, for organizing this course. And thank you the whole IFSO and the SACO team for the cooperation to organize this. I think this talk very nicely follows the robotic talk as well, because this is all about pushing the boundary. And I think that's why we wanted to have this talk. The next step, day case bariatric surgery. So I'm Chetan Parmar, one of the bariatric consultants working in north of London. And anybody coming to London are more than welcome to visit us or use us as an excuse to visit to London. Those are my disclosures. Nothing related probably to this talk, but related probably to this course. Majority of my work, 70% of my work is now OAGBs. And I started as a Roux-en-Y surgeon, and then I slowly moved on to become a more of a OAGB surgeon, and then less Roux-en-Ys and sleeves. So let's go to exactly what we were talking of lap chole and stuff here. So I think there is enough evidence out there now that bariatric surgery or metabolic bariatric surgery, what we call it these days, is safe as other common operation. And this probably is the largest MBS equipped paper out there of nearly 1.6 million patients, in which around 11.1% of the patients had metabolic bariatric surgery. And they compared it to the routine operations, what we call the cholecystectomies, appendectomies, and hernia operations. And it showed that the odds of readmission, reoperation, and mortality compared favorably for the MBS compared to the other operation. That means we have now established that inpatient metabolic bariatric surgery is safe and probably even safer than other operations. Then why can't we do it as day case? Now, I just want to define the day case here, because if you look at all the historical paper from USA, day case means they have a patient operate, they go to the next door hotel, or some papers where they come in the morning at 10, and if they are discharged next day morning at 7, because they are less than 24 hours, they are still defined as day case. So this is not about those kind of day cases. These are the same day discharge where you have the patient in the morning, and just like a gallbladder and a hernia, by evening 5 o'clock or 6 o'clock, they are home. So why push for day case metabolic bariatric surgery? I'll briefly touch on those things. So I think obviously we know it improves the efficiency and capacity. I think in the current financial constraints, at least in NHS or in the UK, we focus more on complex cancer cases, high demands, and as soon as we have that, our bariatric list gets cancelled or postponed. I don't know what's out there for other countries, but this is what we commonly face. Also, it has a knock-on effect that adds on to our high waiting list, and as you all know, therefore, at least in UK, we struggle because as soon as you have 1 year waiting list, patient then go abroad, have the operation, come back with complications, and it becomes a vicious cycle because then we are dealing with that rather than dealing with our primary straightforward cases. We talked of laparoscopic surgery. Carlos in the morning showed about robotic surgery, and I think all of those we know does contribute to quicker recovery, early mobilization, and ultimately patient going home early. We don't actually count on the economic side of things, but at least in the UK we have proved these patients then go quicker to work as well, which ultimately helps the bigger economics side of things as well. We are quite poor at collecting the quality of life. If you look at MAUD paper or any other papers, when it comes to quality of life data, it's zero recording. We only focus on weight loss and those things, but quality of life is poor. So again, I think if you talk to the patients, they do want to prefer to go home the same day if it is safe and feasible, right? And this all adds up. And we know that the obesity burden is not going to reduce in the world. There is headlines now that by 2050, 50% of our adults in the world are going to be either overweight or suffer with obesity. So we do need to find working more efficiently in dealing with this condition. I won't go in detail, but I think you all raised your hand when I asked the question about pharmacotherapy. It's rising in popularity in the same way endoscopic interventions are rising in popularity as well. People or patients are preferring less invasive operations. Therefore, we have to also try and modify and justify that, okay, guys, this is safe. We can even send you home in a day or so. Again, probably in the all health service, when it comes to post-pandemic, we have all struggled with just getting the same number of cases, at least in the UK. We are not there. We are probably working as 80% capacity of what we were pre-pandemic, and I really doubt that that's going to change in the next few years. So UK as a country, what we are doing is there is a society called the Day Case, or it's known as the BADS. It's the British Association of Day Case Society, and there is something known as GOFT, Get It Right First Time. It's an NIHR and a government collaboration work where they are working together, and with the British Obesity Metabolic Surgery Society. What we are trying to do is, we are trying to say, how can we increase our day case rate in bariatric surgery up to 15 or 20% nationally? And that's the reason that is all happening, and we thought it's worth just talking on that here as well. Simultaneously, I think what was happening was, in the Big If So as well, we decided to look at same-day discharge, and that's why we focused on the name here, same-day discharge after metabolic bariatric surgery, and we came up with an if-so position statement. So I mainly wanted to touch on that as well, to raise that awareness so that everybody can at least go back to their hospitals and explore this option. Two main questions when we start any position statement, just to get a bit of an idea that when we are doing any position statement, we need to obviously get an idea what is the conclusion we are going to get. So here we had two questions. PICO 1 was, in patients undergoing primary metabolic bariatric surgery, is same-day discharge compared to conventional surgery has efficacy and safety? And 2 was, this was primary, 2 was whether in the same way a revisional or a conversional surgery is safe and efficient for compared to conventional metabolic surgery. So we went around doing the systematic review. We found all these papers. We won't go obviously in detail with all of them, but to summarize what we found was we had 17 studies, and we actually had good number of patients, nearly 47,000 of patients. We also had some RCTs, so there were around 4 randomized trials with around 2,000 plus patients in this study as well. What we found was the mean age in the randomized trial was 37 compared to the observational. So in this talk now, I'll be comparing kind of the 4 randomized trial and the other observational retrospective or prospective studies, just to get an idea between that comparison, okay? So in the randomized trial, the mean age was 37. In the observational, mean age was higher. In the same way, in randomized trial, the mean BMI was 41. The mean BMI for observational was 43. Means for randomized trial, the age and the BMI was less compared to the observational or retrospective or prospective studies. What it showed. This is what it showed. So this is the 4 randomized trial. Again, that's the plot, but won't go in detail. To summarize, nearly 2,000 patients. What it showed was there was no statistically significant difference between same-day discharge and conventional inpatient group in terms of complication, readmission, and 30-day mortality. So to sum it up, randomized trial showed that same-day discharge was as safe as you would keep the patient in for a 1 day or 2 day, and that's what the evidence out there at the moment. What happens, because this is only 2,000 patients, remember we have total 46,000. What happened for the other 42 kind of thousand patient? This is what it showed. So in that as well, when you compare that cohort of patient with your conventional, we found that rate of complications and rate of admissions were not statistically significant. The only one difference which was a bit worrying when we first looked at it was when it came to mortality, we found that mortality in the same day discharge cohort was significantly higher compared to the observational cohort patient. So obviously we wanted to look into more detail into that, and we found that that was actually largely influenced by just one study which had 60,000 patients in those arms, and that's that study out there. Also, majority of those studies then didn't really give the detail of mortality in totality. So what we then did is we went and individually looked at all the studies, and what we found was that that data was really kind of not clear. Myocardial infarction, probably yes, leak and hemorrhage, I would give a bit of contribution, but then sleep apnea, sepsis, again, I would probably say yes, related to bariatric surgery, but respiratory failure, emphysema, and so on and so forth were labeled as cause of death. So then we looked at more details, and then what we found was same-day discharge. If you look at the mortality, none of the patient died within 48 hours. All those mortalities were readmission after 2 days to a median of around 8 days or to 21. And then I could assume that the patient would have gone home the next day anyway and then come back in the same way. So that's what we found out from the mortality side of things. This is a simple graph rather than those forest plots and complete graph to show. And as you can see, this is our same-day discharge and control, and this in distribution. And this is with the observational studies is on this side. And here, that's the mortality compared to this one. Okay, but I explained to you in simple terms already. Then the question comes, which operation is safer, Roux-en-Y operation or sleeve gastrectomy? When we analyze the meta-analysis, we obviously looked at the strength and the grading, and we found, so that was the PICO one. Remember the primary bariatric surgery. In that we found that same-day discharge can be offered to selected patient for sleeve gastrectomy. The evidence was strong and moderate grade. Same way for Roux-en-Y gastric bypass, it favored in favor of Roux-en-Y and sleeve both. So they both are considered safe. OAGB, there is not much data out there. SADI, there is not much data out there. It's only one few patient series, so that was not included in this analysis. In the same way for revisional bariatric surgery, this was actually negative, means that it should be avoided in patients with significant complication, late surgical end time, or limited access to care. And in the same way, revisional bariatrics should not be offered at the moment because the evidence is really, really low. So that's the PICO 1 and PICO 2, what we managed to get it from there. What was the learning for, or what were the recommendations that what sort of patients could have day case surgery? Looks busy, but effectively it kind of sums up very nicely. 18 to 65 years old, not high age, ASA grade safe, BMI around less than 50, well-controlled diabetes and hypertension. Now, just to remind that, yes, these studies show well-controlled hypertension and diabetes, but if somebody was to start a day case program, don't start with this cohort, because if you go into detail of those patients as well, in the first cohort of patients, they didn't have patients with these comorbidity. Once they got an experience in a robust pathway, then they started going and pushing their boundaries. So yeah, don't start doing that on your first cohort of patient. I think, again, patients needing CPAP is not a good idea. I think this is self-explanatory, psychiatric orders, cardiac failure, and those ones, no. Don't plan any concurrent procedures like lap choles or large hiatus hernias or large hiatal repair. Again, those are not the ideal patients. Try to avoid opiates, and therefore, patients should be able to tolerate your paracetamols and NSAIDs nicely. Also, it's a teamwork, right? So you also need the anesthetist to be a part of the team. For us, this sounds a bit alien sometimes, but yes, I think you need to have those guide. What I realized talking to my anesthetist is that there are cheap anesthetic medications, there are expensive medications like rocuronium and Sugamadex and stuff. Apparently, they are good if you want to have same-day discharge. So you need to have your anesthetist on board as well, because that's what they tend to use for our cohort. Our anesthetist, for example, tends to give dexamethasone, magnesium infusion, and ondansetron empirically for all these patients as well. So have them on board for your cases. This is the final recommendation by the task force based on all the evidence out there. So it shows that for primary sleeves and Roux-en-Y, yes, you could offer them same-day discharge. At the moment, for conversional or revisional bariatric surgery, I think the evidence is little, so that's not supportive, or maybe you could do it as a research protocol. This probably is the key. Preoperative counseling is probably the key. Get the patient early on in the pathway and kind of get them into the thought process of same-day discharge, so that logistics, transport, somebody at home, and all is sorted out. Again, before discharge, conduct a thorough surgical team assessment to check that all their pulses, vitals, and everything is stable before they are discharged. This is home support I talked of. So say at least in London, yes, you could still be only 10 miles away, but you can't come to the hospital for an hour. So they have to somehow be able to reach an acute emergency or somewhere within 30 minutes or 45 minutes in this case. And there should be an adult at home at that night particularly. So that's what they show at the moment. What we have not talked in this, or where the evidence still is lacking or not very robust, is all about ambulatory care. I think lots of hospitals have ambulatory care, so make use of that. We have not talked on all the wearable devices, because a lot of now new same-day discharge teams have wearable and monitoring device, but then the question arises, who monitors them at night and stuff? How do you educate those patients for this monitoring pulse? What pulse? Is it 90, or if it is 91, do you worry, or does it do an alarm? So I think those things have not been looked into. This is something, if you want to again start, which again none of the papers mention, but I think you should focus on for the ergonomics and those side of things. So if you are doing a day case operation, don't put it last on the list. Try to have it first on the list, where you are all energetic, there is no fatigue, and the contributing factors that is are, your team, your setup and all is standard. So please focus on it. None of the paper, interestingly, mention this, but I think you ourselves realize that by the end of the day, you are not 100% probably there to start doing the day case operations. Other, probably again, burnout. Same thing, contributing, if you are stressed, running around for conferences and stuff, probably not good idea to start doing day case on the next morning and stuff. And the reason is, there is good enough evidence to show that when you are tired and not up to mark, your chances of medical errors and poor quality care are increased. And these are all statistically proven. So again, the last two slides, the bottom line is, if you are doing day case, have your first case as your day case, so that you then have time at 5 or 6 o'clock to look at them before they are discharged. Have a relaxing music. It's not just good for us, but for the patients and anesthetists, it's good for us as well, and probably good for the team bonding as well. I ask around and people play their choice, and I think it's one of the way to chill out. Other thing, have a robust setup. So we did this UK study where we looked at, from 2005 to 2020, we looked at all adverse reactions reported nationally for bariatric surgery. We found that 541 bariatric surgery related, they were there, and 150 were attributed to high and low severity. Well, interestingly, 17 of them were just stapling orogastric tubes. Based on that, we developed a nice pathway of what to look of pre-op, intra-op, post-op. So have that team and setup first before starting doing day case surgeries. I won't go in detail, but so we have been amongst the first team in UK to now start doing OAGB. That's our first patient. And I was just amazed how motivated she was. As a surgeon, I remember still going and seeing her at 6 o'clock. She complained of a bit of pain. You could probably see the look. I was a bit more anxious than her, and she's like, no, Prof, I'm happy to go home. So, and that's where that preoperative counseling was important. But she was so much set up to just go home safely and all, and it kind of helped us. So yes, I don't have a large series, but at least we have now few patients where we are doing OAGB as day case. So maybe next year I'll be able to give our experience of it. And again, we didn't just start doing it. It's been years and years of making. So we have had multiple experiences, systematic reviews, looking at all patients, low BMI patients, high BMI patients, revision patients. With IFSO, when Lillian was on as a president, we also had a practical guide published on those, and books, and cancers, and reflux issues, and long-term data, so that the whole team was aware and they all felt safe that yes, we are ready to push that envelope to start doing day case bariatric surgery. So I think that's the key there. So to conclude, my friends, I think yes, it's time now that we can do same-day discharge metabolic bariatric surgery. It's feasible, it is safe, and I think with the new advent of minimally invasive surgery with robots and all, probably we should be able to do it more. Yes, strict to strict inclusion criteria. You saw the IFSO statement was less than 50 BMI. When even now, we are doing less than 45 BMI patients with no diabetes and only one antihypertensive. So we are playing it safe till we do our first 50. It's all about teamwork as well. So get a good team who knows what you are doing when you want to start doing it. Have a robust discharge planning. Yes, there are a lot of teams who are doing variables and all, but when we decided that, okay, we are going to do exactly what we do for gallbladders and hernias. We are not going to give them remote monitoring. We are not going to ring them at 9 o'clock, 10 o'clock, 11 o'clock at night. We are going to just let them go home at 6 o'clock. Next day morning, 10 o'clock, our nurse rings them. They obviously have phone number for our A&E, So if anything goes wrong, they can make that phone call, have a structured follow-up. That's the only change we had. And the key, guys, I always say this, share your mistakes so that we can prevent other people from making them. To end with that, thank you again. And well, we have our British Society meeting next month. We have a session on daycare surgery there as well, so you're welcome. And we have our joint IFSO-EC and IASO Congress next year in Munich. So plan your days. And Nasser and team are planning this summit in Frankfurt. So looking forward to be there. And if you guys want to learn more about OAGB, register for that as well. So thank you.